oxygen saturations or work of breathing, or a combination of those two things?
Well, ventilate would be a rise in CO2 as compared to low oxygen. So it would be more that if they're getting exhausted and not able to maintain their ventilation. It could be oxygenation as well, depends on the clinical picture, but we don't have one single criteria to decide on when we'll use CPAP or high flow oxygen.
So if you had a patient that you were treating in front of you, you wouldn't be measuring their CO2 continuously, I'd presume. So is it more if you feel like they're tiring and their cognitive state is worsening that you would start thinking about whether you were going to use high flow?
If they're coming in and are really bad, I will start immediately, so I don't need any first treatment. If I see that he's exhausted and he's not even able to breathe properly, we'll go directly. And the other patients that are severely ill but are somehow responding, we'll use blood gas analysis, which is right on the spot.
And you use
the difference between
So you would use the blood gas analysis sort of quite regularly in those sicker patients to help determine the success of their ventilation?
It's a bit difficult to say because, it depends on the whole picture.
So,
if we see that he's starting to deteriorate and he's getting exhausted and not breathing properly anymore, I don't need blood gas analysis to know what I need to do.
Yes.
On the other hand, we have these patients that are breathing really heavily, starting with CO2 of 45 maybe, and we already know if they're not improving properly, they will eventually need something else, and then it might help.
Yes. Okay. In the circumstance that you work in, does your access to resources influence the treatment you use?
It does.
In what way?
Intensive care for the treatment of the severe and life-threatening asthma patients. So it depends on these kind of resources.
Yeah. Okay. And I'm sure that you do, considering your seniority, but this is just a question I'm asking everyone. Do you feel you have the necessary skills to administer the treatment regime that you would like to use in children with severe asthma?
Yeah.
Yeah.
I do. Yeah.
And when you think about either initially starting or needing to escalate to more invasive treatment, so by that I'm talking about IV treatment or more invasive ventilation, what are you trying to change for that child? So you mentioned before that you use the PRAM score. Do you actively record and reassess the PRAM score as you give treatment to a child?
We should. Some of us do, not all of us, but it's the official criteria in between others, because we need the oxygen, work of breathing, respiratory rate, consciousness, all these criteria as well that will be documented before change.
Okay.
But that sometimes it's theory, and the praxis would be that someone would just go on changing the treatment, and in the end they will document whatever was the reason for the change of treatment.
Yeah. It's very interesting because we, in Australia and New Zealand, the people I've interviewed, and anecdotally, we don't use clinical asthma scores. It's interesting that you're saying that's such a predominant feature in the way you assess and manage children. Okay. What worries you most about children with acute severe asthma?
I mean, what part of the picture, or what feature of the clinical status, or?
So when we think about when we're seeing sick kids, and when we're instituting treatment, we're trying to change something because we're worried about either progression of disease or, outcome for the child. So when you're standing there in front of a child with acute severe asthma, what worries you the most?
Exhaustion of the patient and not being able to usually if the really severely ill, they will not be able to breathe out anymore at all. So I would worry about how to get the air out of the patient, but that's more in the sense of the actual patient. So in that situation, it's mostly about the acutely deteriorating child.
Yeah. And I guess, would it be fair to say that you're sort of trying to prevent ultimately respiratory arrest?
Yeah.
Okay. Do you think that your treatment regime that you would use would be similar to your colleagues or people elsewhere in Switzerland?
It actually would be similar to the treatment of my colleagues because we have internal guidelines. They will not be the same as in the rest of Switzerland.
Okay.
I guess the majority don't use aminophelins in Switzerland.
Mm-hmm.
But when to change, what kind of non-invasive techniques, the use of magnesium, I'm pretty certain that's different from hospital to hospital.
Okay. And why do you think that is?
Well, I'm not sure if you know that there's no, every region has their same healthcare system. So they're quite independently working and growing.
Right.
So it's, there's no reason why it should be similar.
Right. Okay. So
it would be useful to have something like that, but there's never been something like an institutionalized guideline for Switzerland.
Okay. So you think that, or you feel that each local health network has their own guidelines?
Yeah.
Okay. And how do you think they would differ? Do you have a sense, or do you know how your practice might differ to a different health network in Switzerland?
Well, one is where if you have more or less access to intensive care treatments, you would do differently. So if you do have CPAP, if you do have high flow, that is completely different from a hospital that is not using that or having BPAP or something like a local possibilities. That is one thing. I know that some hospitals use magnesium, others don't even use magnesium. They use just polysabutamol IV or change to epinephrine in small doses. So that is really differing depending on the background of the department leader and on their intensive care team as well.
Okay. And has your practice changed in the last couple of years or in the last 5 years, or do you feel like it's been sort of the same?
No, magnesium has started over the last few years. So I think we introduced it about 4 years ago, something like that. That is different. The rest has not changed very much, I guess.
And why do you think magnesium came to be used more in your department? Do you think that was people's personal experience or research in the field, or what do you think sort of prompted that shift?
Well, one would surely be that our emergency department has gone more independently of intensive care. Before, life-threatening patients with asthma would go directly to intensive care. We wouldn't even treat them. The other would be that research has shown more and more data that was really good I think it was good before, but we have a